Hi there, my name's Rich Williams. I'm one of the ENT registrars from the Southwest. Many thanks for asking me to come back and talk to you about nighttime emergency department secondment, which is a project that I've done a number of years ago now, but I've come back to obviously tell you about it. Next slide, please. Okay, so here's the poster as it was last year, and what we'll do, I'll canter you around it and explain as we go through. So, background. Essentially, we're all working in a tight and busy working practices. In the NHS nowadays, there's declining working hours with the European Working Time Directive. Budgets are tight and training numbers are dropping. And the literature warns of problems with the patients in surgically cross-covered departments with the advent of hospital at night and other such initiatives. Gave us a problem down in Derriford, which is very typical of a tertiary referral centre serving a large population, where again typically the ENT surgical rota was matched with the plastics department in a cross-cover system for their out-of-hours care. Nevertheless, numbers were tight when I started there, but in August 2011 it was suggested that the number of doctors would be reduced again from 12 to 10 as a result of removal of 2 of the training numbers. The problem was set to the managers to provide a solution to this, and obviously their problems involved trying not to spend any more money than could be possible, and their 2 obvious and preferred options were to increase the interdepartmental cross-cover within the hospital by allying us with a further specialty. This would have the consequent dilution of knowledge base, with the junior doctors being less and less specialised in the specific areas of plastic surgery and ENT, along with the other specialty. Their other option was to increase the amount of compensatory leave. Now, New Deal criteria allows out of hours and weekend working to be compensated for by extra days off within the rota, but unfortunately this meant reduction in the amount of training sessions that each of the trainee would be able to attend. So moving on to the first cycle of the audit, what we tried to do to begin with was establish the hospital nighttime working practices of the ENT and plastics junior doctor over a 6-week period. The gold standards we assessed against was the clinical quality indicators employed by the emergency department for the seeing and treating of their patients, along with the analysis of hospital at night data, which captured the ward tasks and their completion by that junior doctor. So after looking at the data from the first cycle of the audit, we devised an intervention to hopefully counteract some of the problems that we've faced, and that was the secondment of the nighttime ENT plastic surgical junior doctor to the A&E department as their primary place of work. The specifics of that created the job description where by between 8 and 9 ward-based doctor-to-doctor handover would occur, upon which the doctor would proceed to the ED minors and be based there between the hours of 9 o'clock in the evening and 7 in the morning, and then followed by detailed handover to the morning and daytime staff. Whilst in the E&D department, their responsibility would be to see and treat all potential ENT and plastic surgical cases upon presentation to the department, i.e. without needing prior clerking by the ED junior doctors. If there were tasks to be achieved within the ward, they could be recalled at any time using the hospital at night bleep system, and the clinical supervision was formalised with patients not followed up by the ENT and plastic surgical department, held under the clinical supervision of the ED middle grade. So once this had been fostered and duly adopted by the hospital, prospective audit cycles were carried out thereafter to show first and foremost the effect and then the sustainability of this system. 2 6-week prospective data collections were performed, again looking at the clinical quality indicators against the gold standards established. An analysis was made on the impact that the change had had on the surgical training experience or or frequency of the trainees. So looking at the results, noticeably in cycle 1 we were non-compliant with both of the key clinical quality indicators, namely the door-to-doctor wait and the breach at 4 hours. But over the second and third cycle we saw a gradual improvement to compliance with these. Patients were staying less time in the department, and the number of patients seen by ENT and plastics increased, along with the number of patients we saw as their first clinical decision maker, as it's called. So in conclusion, as a result of the intervention, the patients received more expedient care by a more complaints-specific clinician, and therefore more expert in their problem that they faced. The ENT department maintained their specialist junior doctor service at night, and there was a reduction in the salary expense paid as the number of doctors employed by the department reduced, and ED were very generous to fund a banding increase, which meant that the juniors received increased salary. And analysing the training experiences between the rotas of the management solution and ours, it revealed a 26% improvement in the number of outpatient and operative sessions that could be attended. The ED department secured improved quality indicators, and ED staff were freed from the burden of dual clerking. So as for all these studies, there is always limitations and lessons to be learnt. One of the key ones was the importance of senior sponsorship to not only get these projects off the ground, but also to maintain and sustain the interventions. Also, the junior doctors that staff the rota are the key to its success, and their enthusiasm can be variable, which obviously has an undermining influence to the objectives. As within all busy hospitals, there's frictions between departments, and each department and individuals within that have their own priorities and agendas, and balancing those was certainly one of the problems with this project, with 3 different departments working together quite closely. And again, as mentioned, there's no point in doing these changes if you can't offer sustained improvement. So further development, re-audit is undergoing at the moment, looking at this sustainability and finding ways to improve and extend the remit of this project. This type of intervention would be usable in other specialties and other hospitals, and indeed we're looking at a similar type of project at the current hospital I'm working in. Again, the hospital at night data alluded to the amount of routine and generic tasks performed at night, and certainly that's an area that further work could be performed, and we'll be looking at that again in due course. So essentially that's all I have to say, and I'll be happy for any questions. Many thanks.